So we go to the emergency room.
Yes, let's go to the emergency room.
You go into a public facility, it's casualty, emergency, casualty. Now, who do you find there? One of the people that you find is Dr. Janet Sugut, who is an emergency physician at the Kenyatta National Hospital. And like we heard from their chairperson yesterday, Kenyatta is the second largest hospital in Africa. Not just a small hospital. Kenyatta National Hospital is the second largest hospital in Africa, both public or private. Dr. Janet Sugut, good morning.
Good morning, and thank you for inviting me here to talk about emergency care. My name is Dr. Janet Sugut. I am a consultant emergency physician at Kenyatta National Hospital. Yes, we are among the people that you find us in the emergency room. Yes.
We'll talk about that emergency room. Because many people don't know where emergency room is Ghani.
Yes.
But to start the conversation, Janet is going to give us the day's quote. She comes up with this, she reads a lot. This girl reads a lot. And then she picks some lines that were said somewhere. And she comes and brings them to us. Just to jog our memory and our thinking. Today's quote, Janet?
CVT. And the line can be my hype guy.
Today who knew journalists also needed hype men?
Yeah, journalists, who knew? Well said, Mariam. Tsitsi Dangaremba once said, when the structures are sick, the people cannot be well. When the structures are sick, the people cannot be well. She made these public remarks back in Harare in 2018. She was talking about different things, but she said, when the structures are sick, the people cannot be well. Sure, it's something that you come face to face with often. When structures are sick, people cannot be well. Yeah.
When structures are sick,
people cannot be well, and that's very true. I mean, like if you think about emergency care is a system, and so if there's a break in any building block of the system, it actually will not work. And what we see at the end when we receive patient is as a result of a broken system. So I totally agree with what he said.
Starting on Eric's question of emergency casualty, take us through what happens in that room, what you come face to face with every day.
And where is it?
Where is it?
Where is it?
You know, you'll know when you have an emergency. That's the day. You'll know exactly where that room is.
And you may not know because you actually
disoriented.
Get there unconscious.
Yeah,
that's true.
Very
you find
true.
yourself in a ward. Where is the emergency room?
So the emergency room is the initial entry point into a hospital. So it is required that every hospital has an emergency area. Why is this important? The emergency area serves as the first contact and the point of stabilization. So say you have a medical emergency. So a medical emergency is like, I have a heart attack. That's the common language out there. In the medical world, we call it acute coronary syndrome. So what has happened? One of your coronaries has blocked, you're not perfusing, or rather blood is not going into your heart, sorry, to use medical terms. So a coronary artery is blocked, blood is not going to your heart. That is a heart attack. You need to be in an emergency room because there are interventions that are done there to prevent you from either dying or getting complications. You get into an accident, you need to be in an emergency room before you get to the operating table. There are things that an emergency doctor will do to ensure that actually a surgeon has a patient to operate on. So that's how critical the emergency room is. So it's usually at the entry of every hospital. And it should be very clear. No one should struggle to know where the emergency room is.
That's true.
In there, we do a lot of things. We do a lot of amazing things, actually. Like in Kenyatta, first of all, you'll come in and there's something called triage. So triage assigns a level of priority because everybody can come into the ER, but they are not all sick, not at the same level. So for us in the emergency department, we prioritize triage. So I want to give care to the most sick patient. So you could have been waiting for an hour, but if I get a category A patient or a red patient according to our triage system, I will take him there. And that is what emergency care is, all right? We deal with the golden hour. The golden hour is very important. So if I'm not able to intervene within that hour, it means either there's going to be a mortality, which is death, or complications from what you have. So after triage now, we decide, are you too sick? do you need to be in a critical care room? Now, in the emergency department, we are able to give critical care interventions. So we will start on IV fluids. We're even able to put you on a machine to help you breathe, what we call a ventilator. We are able to now, from there, we call in the multidisciplinary team. If you need to go to theater, I will call in the surgeon. So we are a linkage between what is happening outside the hospital and whatever is happening inside the hospital. So my decision at the end of the day is this patient going to theater? Is this patient going to an ICU? Is this patient stable enough to go to a ward? So that's, in summary, what emergency is.
Are there enough trauma specialists in Kenya, or even at KNH? Enough trauma specialists, because it sounds like that's a spectrum of trauma interventions.
It is a spectrum of trauma interventions. We have, as KNH, we have specialists. We still need more, but currently we are adequate to serve the population as it is. We have neurosurgeons, we have general surgeons, we have orthopedic surgeons. Now, these are multidisciplinary teams that will be needed to just treat one patient. So you can find that one patient requires 5 doctors for that patient to be stable. So that's how also costly healthcare is. If you need 5 specialists to be able to stabilize you, that is what is happening. But at Kenyatta, we have those specialists. We bring them on board as depending with now what I have assessed. What doctor do I need? If I need a cardiologist, for example, I bring them on board, because remember, there is trauma and there is also the medical part, the medical emergencies.
This is a hospital, Daktari.
Yeah.
Hospitals ask for money. Where is the money question coming in this whole thing? Because it's arrived, it's an emergency, it's a victim of an accident. They have arrived going through triage, it's at golden hour, then there's a critical care room and all, and then multidisciplinary pesa.
It's a very valid question, and thanks for asking that. I'm sure everybody is wondering. So I want to do before and after. So before SHA came in with the emergency care fund, and now what is happening. So before, what as a hospital we used to do, emergency is an emergency. And the Constitution of Kenya says we have to give the care. The World Health Assembly of 2019 says we have to give the emergency care. It's a right. So regardless of status, if you meet the emergency criteria, what we used to do is take you in and start the treatment. That is what Kenyatta has been doing for a long time. So we have social workers in the department who will then assess ability to pay. But it doesn't stop a patient from getting emergency care, because our focus is to save life first. Money comes second. Now then the social worker will follow up the patient, try and get the relative. Remember, in Kenyatta we get unknown patients. Patients who are just picked from the street. We do not know their relatives. We treat them. That's our role. And then there's a whole finance department who will now take care of the financing bit. Now after the SHA, we now have the emergency care fund. And I really want to applaud the government for bringing this in. It is a lifesaver. It's a game changer, I would say. If you look at the emergency care policy that was launched, one of the recommendations was a funding model for emergency care. So with the emergency care fund, we are able to take care of an emergency patient within 24 hours. You meet the criteria for emergency. An emergency is any condition that is life-threatening. That's an emergency. We take you in under emergency care fund, and you don't need to pay as long as you're an emergency. Now the non-urgent cases, now those are cases that now we probably, have to pay for that service because they're not an emergency.
Okay.
Yeah.
Let me begin with the question. So even if I am not a registered member of SHA, as it stands, I can get emergency and critical care.
Yes.
Yes.
At KNH and in any other level 6, that is what is happening.
Okay. Now that you've brought in the level 6, that was my next question. What level hospitals have emergency and trauma centers? Because I think you see it in big hospitals, and you're right, it'll usually be at the very entrance and it's clear as day. But does a dispensary have a trauma and emergency section? Does a level 3, level 4? And
So this we have to think about it as a system. Like I said, there are levels of trauma centers. A level 1 trauma center, it's an American way of grading a trauma center, but a level 1 like Kenyatta, for example, which we are actually working towards that accreditation because we have everything. We have super specialists, 24-hour coverage. We are doing training and research in partnership with UN, KEMRI. They're able to do much more, treat more severe injuries. At lower level, they still have a role. Because remember, the accidents happen anywhere. Emergencies happen anywhere. So as a lower level facility should be able to give the initial emergency care and determine that they need to refer. Now, what happens is sometimes that decision making is a bit slow. So by the time they reach to actually where they need to get definitive care, it's pretty too late. So through the societies that we have the Surgical Trauma Society in Kenya. There's need to actually grade the facilities. And I want to just mention Emergency Medicine Kenya Foundation, who've done well to map out the trauma centers. So a trauma center should have an emergency doctor, should have a surgeon, and should have a theater, and it should run 24/7. So it's just that the spectrum of injuries that they're able to manage. Yes.
Mariam, was there another question you'd ask? Because I wanted to...
that one specifically, I wanted to know. And it's good to know that there's levels as well to
exactly.
trauma care. But the bare minimum is an emergency doctor, a surgeon, a
theater,
and it runs
24/7.
So these are level 4s.
Yes.
Yeah.
Basically.
A lot of Kenyans die on the way to hospital. So is that lack of ambulances, which I know we've talked about? You've talked about medicine. Is there enough medication to treat trauma events? But take us through why so many die on the way. Some could argue that happens everywhere. Of course, different countries, in developed countries, have that intervention on the scene. So people's chances of survival, some could say they're higher.
Yeah.
But yeah, some might argue, why do so many Kenyans die on the way to hospital?
And then, so the role of the EMS specialists.
Right.
Those ambulance people.
Yeah.
I feel like they have the first contact with that trauma before they even come to.
I mean, in the cases where someone does have access to an ambulance, because a lot of the times as well, they don't.
Yeah. So then what's the
what's the gap?
What's the gap?
So like I said, it's a system, right? If you look at the WHO emergency care framework, the care should start at scene. So there's a role of bystander. You as Janet Mbugwa, you as Latif, as Marian, there's a role you have to play for me to be able to get this patient alive and to take to theater. So if you look at bystander response, we still have gaps there because people don't know what to do in an emergency. Leave alone even an accident. Someone collapses in your house. The first thing is you want to rush them to hospital yourself.
Yep.
But if you're able to, if there's a working system, what should happen is I should call a dispatch center, a call center, who have qualified personnel and will actually give you advice on what to do as you wait for an ambulance to be dispatched. And when this ambulance reaches the scene, there are interventions that are started at scene. So first of all, how many ambulances are at our reach? You know, how long will I wait for an ambulance? And if the ambulance arrives, who is in the ambulance? How trained is the personnel to manage the emergency? Remember, there are things that cannot wait. Case in point, if I get trauma, I could accumulate air around my chest. If there's no acumen to relieve that pressure, I will die. Yes, you have the ambulance, you have the personnel, but the emergency has not been picked. So what kind of personnel are in the ambulance? Number two is what equipment is in the ambulance. If I need to be intubated means I'm putting a tube down your throat to help you breathe. Is the EMS able to do that in our setting? I've been in settings in the US where a patient comes to you and already everything has been done. You're literally asking yourself, what am I doing as an emergency doctor? You're just disposing the patient. So you see, the golden hour has been taken care of because the care has started at scene. So we still have gaps in that in terms of a national emergency ambulance system. Nairobi County is trying. We have the Emergency Operations Center, but they still have challenges with the number of ambulances, regulating training for EMTs, and also equipping the ambulances and just maintaining them, you know. They have a short code number. How many of us know that number?
Right. Is it 999?
Nope.
Oh, God.
Exactly. So
what is it?
So it's 1508. That's the toll
remember
free.
we were told by, who told us? The chief officer, the county secretary.
You're right, he did.
The
give us
Nairobi County
15.
Secretary.
1508.
Yeah.
And it's functional, it's reliant,
Toll free
everything.
number,
These people
24/7.
of Nairobi, they are the ones who regulate all these billboards. You'd expect that Nairobi would at least be putting up the billboards and say, in case of an emergency,
Exactly.
this is the number for us to know.
Exactly.
Yeah.
Lakini sasa how? Anyway,
So even at the scene, the accident scene,
Yes.
1508,
I
they walk
should-
you through as you're waiting. Do
Yes.
this, take a cloth, cover this thing. And
Exactly. Wait for an
Okay.
ambulance. We are dispatching. The ambulance brings the patient to the hospital. That is how the system should work. And it should not be, it's care during transport. I just want to insist on that. Care during transport.
it's not just transport.
Not just a vehicle. Which is sometimes the case.
Yes, many
Yes,
times.
many
not just
times.
sometimes, many
And
times.
actually, patients just come with their own means.
Yes.
And by the time we receive the patient, they're long gone.
So you say we have an emergency care policy.
Yes.
The policy talks about us having such structures.
Yep.
The quote again today, Janet?
when the systems are sick.
The people can't be well.
Yes.
Okay. So we have a policy in place that says that we should have this, that in the event of an emergency at scene, there should be this kind of response. Ambulances available, personnel, well-trained personnel, well-equipped, arrive at a facility, and this is the kind of care that you receive. There's even now a fund that's funded from the exchequer that takes care of you for the first 24 hours. Where are the gaps in the implementation? Is it a lack of knowledge by those that are responsible, the duty bearers? Or, well, let's not even talk about the lack of money. Is it a lack, do they know? Duty bearers here, Daktari, starts with county governments.
Yes.
First of all, the national government, but then county governments.
Yeah.
Are they aware?
I believe they are aware because, I mean, a policy, now that health is devolved, a policy is created in collaboration with the county governments and the national governments. We just need to start doing the work. And I believe there could be some work going on. Probably we'll see the fruits in the next few years. But we should start doing the work because now we have a backing of a policy. And start looking at your system in your county, in Nairobi, in Nyandarua, whatever, any other county. Is the system working? Is that patient at the lowest level able to access ambulance? Because you're talking about universal emergency access. So because I am able to call for an ambulance should not determine, that another person is not able to. It should be.
It should be, there should be equity.
Exactly.
Across the board.
Exactly.
Yeah.
My grandmother should be able to call for an ambulance.
Everybody should.
Yeah.
So if we say that at the very basic, governors would know and they'll be told about this, county assemblies should know, right?
Yeah.
And then the citizens should also know.
Yep.
So that we are able to push for proper funding and resourcing of an emergency system that works for us.
Yes. That is what should happen.
That's
Okay.
What are the main trauma incidents that you encounter? I know that's broad.
Yeah.
On a day-to-day, is it road accidents? Is it violence? Unfortunately, I think we've talked before. Gender-based violence is also a trauma.
It is a trauma.
That you respond.
Yeah.
But yeah, in terms of maybe let's say the top three, that every day you have to see this case of trauma. Or does it vary?
In my hospital, Kenyatta, we see a lot of road traffic accidents and assaults. Those are the top two. Assaults, either by known or unknown persons. So someone stabbing someone else, someone shooting someone else because of conflict. And even when you talk about the recent protests that we've been seeing, those are the kinds of traumas that we see. And if you look at road traffic accidents, it really tells more about our systems again. How safe are we on the roads? Are we wearing our seatbelt? The very basic things, actually, very very basic. How are we safe on the roads? The Nduthi guy, are they wearing the right gear? Because these things have been studied. If you put on a helmet and you get into an accident, the injury will be less.
Yeah.
But what do I see? I see patients coming and their skulls are open and all those things, such things.
Yeah.
So there is a lot to be done. That's what I'm saying. Prevention is good. We don't want you to come to hospital you know, and we cannot do much. Let's prevent this. Let's do what the government is telling us. The system that have been put in place, roadworthy vehicles. Those are where we start. Right. Yeah.
Does Kenyatta National Hospital have a separate word for boda boda riders? I see it on the internet, like, and it's anecdotal. I don't know if it's real, or is it just a story, or is it that there's a disproportionate amount of accidents that arise from boda bodas?
So remember, when someone gets into an accident, they get injuries in several parts. So how we've reorganized our system is to take care of the different specialties. So we have orthopedic, which takes care of bone. Then we have cardiothoracic, we'll take care of chest injuries. We'll have neurosurgery, which will take care of. So if they have multidisciplinary, we look at the highest level of injury that is, you know, like that carries the highest burden, and that is where the patient will go. But I also want to say that we are reorganizing our department. Like now we have International Trauma Center, and it will look at that. Where do we keep these patients initially before we take them to the specialties? So general trauma. So we are expanding our spaces. Like I said, we are looking for accreditation for a level 1 trauma center. And let's see how that goes.
There's some feedback here. Bakari Sagne is saying, if blood is donated, why is the transfusion so expensive? Shouldn't taxpayers cover the processing and administrative costs to make emergency transfusions free for patients?
Initially, it should be free. I mean, especially that they are donating. It's actually free, if I'm not wrong, unless that is in a private facility. I'm not certain. But in public facilities, blood donation is free. But remember, we are seeing a lot of trauma. We run out. So we really, sometimes when you come in, we will ask you to donate so that we're able to help the next patient. Yes, we will give you the blood right now, but then we will ask you to help us donate if you meet the criteria.
For the blood banks.
Yeah.
So then when you see the calls for blood, usually blood has already been given.
Yep.
It's now restorative,
Yes.
in a sense.
Exactly. Just filling in the bank. Because we will not deny you blood, especially in emergency. If I'm losing blood, I need blood. Even if you give me 10 gallons of water, it won't help me. I need blood. So we will give you the blood and then now look at mechanism of replacing what we have used. Yeah.
He's also asked, what's the role of police officers in emergency response? Can police land cruisers be used to transport patients to hospitals? I think we've seen that happen numerous times. What is their role?
So police officers are they're part of bystander. There are things they can do as they wait for the appropriate. Remember the appropriate vehicle. Exactly. Because what is happening in a Land Cruiser? What's going on? You're just there at the back of you. You don't have an IV line. No fluid is going in. So there's no care being given. Yes, they're transporting you, but there's no care being given. So we want ambulances to transport patients.
But Dr. let's to deal na vitu kwa ground. Okay. We don't have these things.
We don't.
So what's the best thing that we can do? An accident has occurred.
Yes.
Let's just deal with road accidents. We see them a lot. An accident has occurred. You are the first one to arrive at the scene.
Yes.
Okay. People are trapped in the vehicle. What do you do as the first, like you said, the first person to arrive? I don't have a number that I can call. I don't know that number. There is no ambulance nearby that I can call. The next level 4 hospital is about 80 kilometers away, 40 kilometers or so. So what do we do in this case?
So when you reach a scene, what you need to do is call for help. Because you as a person might not be able to handle the situation. So your role as a bystander is calling for help. And we should be able to call the police, right? Because the police can call the fire. Remember, fire people are able to extricate a person from a vehicle. They're able to cut through the vehicle and get the person out safely. They have those tools, they've been trained. But you as a bystander, your first instinct would be, check the patient out.
What you?
And no?
That's what that first instinct is.
Yeah. But you're causing more injuries, and that is what we don't realize. We're causing more injuries. So call the police. Police will call the fire. But again, we want to make use of the call center. Because as much as they might not have all the ambulances, remember they're in partnership with private ambulances. There could be an ambulance near you. So that is when we want, let's do the ideal. Let's try and do the ideal. As much as we know our system is not as ready, but we need to start doing the work. Like we said, we need to start doing the work. Yeah.
Because that helps to keep this person alive, at least to save their life.
Exactly.
That's
Ngumu lakini.
okay.
Ningumu, yes, I know.
Ngumu sana.
But other systems have done it, right? Why can't we do it?
Right.
We can do it.
Okay, so it's only it should only be like a last resort that then someone is going either privately or in a police land cruiser and things like that.
Yep.
Okay.
I feel like we have to fix our perception
Yes.
of dealing with people when they're in that
State.
Because that's something that I don't know if it makes sense. But if we haven't been trained, like what you said about bystander, I almost feel like that should be a PSA every hour. If you see this happen on the road, if you see
Yes.
somebody in this
Call.
condition,
Yes.
otherwise first I'll either scream, faint, panic, run away
Very true.
before I consider pulling the person. And maybe that's part of the thing is that our relationship with blood,
Yeah.
our interaction with hurt people.
Awareness as well. It
Yeah.
wasn't by accident, I believe, that Hollywood came up with these movies. An accident has occurred, you're there, but you see someone saying, call 911.
Exactly.
So it's top of mind.
They created that because always I ask the question, where upige? I mean, why do you have to tell somebody else
Just
to
to
call? But then
call.
if you think about it, it's scripted that way so that you pass on the message that in such a situation, call 911.
Exactly.
Right?
Someone has to say it out loud.
Yes.
Because if they just start dialing,
Yes.
No one knows what's
You
happening.
know.
yeah.
Ati so wapigie.
So big.
So there's something called a chain of command. So
Yes.
if Lati, for example, you're the first on scene, you're the one who is initiating
I'm the
that
boss there.
command. You're the boss. You're like, hey, can you call 911? Can you call the police so that all these people come and you're able to sort the patient? Non-trauma. I want to talk about non-trauma for a minute. If someone say collapses in nation media, what would you do? You have no idea.
Fungua madirisha.
Tumtoe nguo.
Fungue shati.
Oh my God, it's unfortunate, but it's
That's what
the
happened.
truth.
true.
Mfungue shati.
It's
Yeah.
true.
Fungueni madirisha.
Yeah? Emergencies happen everywhere.
Yeah.
Are we ready? Are we teaching our children in school how to respond to emergency? Remember, now for us, we are older. That's why it's very hard to do a culture change. But if you start when they are very young, are we incorporating these teachings in school? If you teach your child today, they will never forget. And if they actually grow and find a patient, they will probably be doing the right thing, more than we can do. Yeah.
I like that the thread of even getting to children when they're young. I'm thinking through the systemic barriers to emergency care in Kenya. There's the obvious that we've spoken to, which is understaffing. I think at Kenyatta you've said, you know what, we're okay, we could use more, but we're doing all right, and we're trying to get that level 1 accreditation globally. Across the country, what does the situation look like for emergency care? Because you could do all the right things, get the ambulance, and then get to the hospital, and your nearest level 4, which has these things that you've mentioned, an emergency doctor, a surgeon, a theater, it's 80 kilometers away, like Latif said, and 80 kilometers of rough road.
Yes.
So I think we have to be intentional. We have to be very intentional about funding healthcare, funding emergency care. All right. So in terms of investing in the equipment that is needed, investing in the infrastructure, the spaces. So in a county, they should map out their emergency centers, because if you have a bigger population, you might need more than one. Not everybody should be coming to a central point. So back to governance, at the county level, what is the conversation that is going on as regards to emergency care? Are we able to take care of our population? All right. Remember, you can have lower level trauma centers that can refer now to the main trauma center.
Right.
So there should be intentional conversation about infrastructure, about funding. We need to be intentional about developing emergency care personnel. I will tell you for free, we are about 7 emergency doctors in this country. So that's a drop in the ocean, right?
How many are at Kenyatta National Hospital?
I'm the only one.
Oh my God.
And it's actually, I'm less than a year old. I've worked in Kenyatta for a while. I've had to go to school.
Yeah.
And so Kenyatta has placed itself in a better position if you look at all level 6 hospitals that you have an emergency doctor. But we want this replicated up to the lower level facilities. But we also have we have diploma courses that are going on. MTC are training diploma courses. We have other short courses. Specialized emergency nursing, Kenyatta does that, and many other institutions. So we should go to that area of specialization so that when you get to the emergency department, you're meeting someone who knows what they need to do. So there's a lot to be done, but we have to be intentional.
So that's such a, I'm sorry, man. The fact that we have 7 emergency doctors in Kenya, now it doesn't matter how many level 4s we have. I was even working from level 4s as being the basics of a trauma center. But if there's only 7 in Kenya,
there's a big, why?
Huge
Is
gap.
is it that it's a new discipline? And so we just started training? Because like you, so this is a beyond a master's program.
So this is a master's program.
Okay.
So we are still, so like I said, we have many diploma programs, emergency and critical care diploma programs. So even the level 4s are not, it's not a raw deal because we still have that. We've been running basic courses. We have short courses that teaches someone how to approach an emergency. We have BLS, we have ACLS, we have ATLS, this Trauma Society, Surgical Society of Kenya have been doing a good job. So it doesn't mean that the lower level hospitals do not have any emergency knowledge at all. They actually do, and they've been running the emergency departments. Now we want to go to a higher level where we now have consultants in emergency medicine, and we want that to spread across as the point of entry. The same way we have cardiologists, we work hand in hand. Yeah.
So when did we start training emergency care?
So for the board, we got, I think it was in 2017 when it was recognized as a specialty. And I will tell you, currently we do not have an emergency medical school. Jomo Kenyatta are starting, and they are still, in that baby steps, but they are doing well, at least they have started. Kenyatta Hospital as well, we are developing a curriculum to be able to train because we need to build capacity. We need to build capacity. So Kenyatta is taking that up to develop a curriculum to be able to train emergency medicine physicians. So personally, I've had to train outside the country because at the time there was no medical school available to train. So like you see, there's a lot to be done.
A lot.
There's a lot to be done.
Considering emergencies and trauma are daily, what's the preparedness around mass casualties, terror attacks, school fires? Obviously, there's gaps. If we're speaking to you're the only one, say in your hospital, what does it look like when you have mass casualty? How is our preparedness around that?
So back again to that, there are courses that have been done. People are empowered in terms of basic emergency care. That in my hospital, we've done very well. We have managed mass casualties before, and we have done well. So mass casualties, again, is a system. You have to think about how you're going to receive the patient, but these are large numbers of patients. So you need to be able to organize your team in terms of managing the number and still maintaining the quality, the quality emergency care. So there has to be preparation in terms of if an emergency happens, what stockpiles do we have? And these you do not prepare on the day, you get ready before. All right, how many people have been trained on ACLS, basic resuscitation? So these are the things the hospital puts in place to ensure that when this happens, people are ready. How do we evacuate the patients we have in the facility, or rather in the emergency room, to create space? So there has to be a mechanism already put in place. You're not thinking through while the emergency is happening. Yes.
So are there do you run drills, for example? How do you prepare for that?
So we do trainings, disaster-specific trainings. We teach people how to respond to a disaster. Remember, disasters are several. There's the trauma. They could be chemical incidents. Even pandemics are disasters. So learning from COVID-19, there are things that the hospital has put in place in case we get an infectious disease. This is how we are running. This is our isolation area. This is where we will admit these patients. Drills, we do drills every once or twice a year. mandatory, and we pick on we can test on different aspects of preparedness. Is it creating surge capacity, or is it receiving the patient? You know, like there are different aspects of disaster that you can actually test. So every year we do drills, and we invite other stakeholders to observe our system, because it's easier when an external person is actually looking at you and telling you, oh, you need to do better there. So that in Kenyatta we do every. I actually chair the disaster committee, so it's actually in my docket to ensure that we are
Those
prepared.
drills are done and that you're prepped.
Twice a year, is that sufficient?
So the organizing a drill is very, it's intensive. If you have to do it regularly, it's really intensive. So we try and do one at half a year and one at the end. But in between, there are many things going on. There are trainings going on, sensitization. Like in Kenyatta, for example, we have trained like firefighters, because when fire starts, I don't want to wait for an external person. I want to start putting out the fires. I wait for help.
Yes.
So we've been able to put out small fires that could have probably escalated. So that's part of preparedness.
Okay.
Yeah.
I like that. How do we lean into the healthcare ecosystem to help with emergency and trauma response? Let me start with even use of technology, AI, and then now personnel from elsewhere. You've spoken to emergency medical service providers and all the other various specialists that are in that ecosystem. How do you lean into that to now help, given that these are very critical moments, like you said? But let me start with technology, if there's ways.
Actually, there was a conversation I was in the other day, and they said a doctor who does not adapt to technology will be irrelevant. The technology is not there to replace us, but to make us efficient. So we cannot run away, we have to. And just to lean on my facility, what we are doing right now is we are trying to go that way. We are actually automating all our systems so that it's even easier to track, to track systems and see where corrective actions need to be put in place. We are looking at also introducing AI into our systems just to make it efficient. I'm happy that the AI conference is happening for the first time. Yes. I'm sure we'll learn a lot. But in terms of triaging,
that requires a person.
Yes, it requires a person. But if you have AI doing that for you, you could use this person to do something else, or have a leaner staff overseeing that triage process. You can use AI in imaging. Like I do many scans in the emergency department. I need all these scans to be read, but they might not all be read at the same time because of the number versus the staff you have. If you can employ AI, I get quick diagnostics. I'm able to give the emergency care as we wait for a definitive report from the radiologist. So there's so much that AI can do. I think we just need to sit and say, where do we want AI to help? All right? Even as a doctor, there are cases I get and I have to really think through what's happening. But with AI, it can simplify and give me differentials, and I quickly get to narrow down and I move on with the patient.
Right. Before you move on from AI, actually, are you struggling with AI doctors, meaning patients coming in with their own diagnosis? Because ChatGPT said it's sprained. Why are you saying it's broken?
I mean, you cannot run away from that, and especially now that everyone is digital right now. As a doctor, you're trained, you have a medical background, so it's your role to demystify to them why you think it's this versus that. And nowadays, there's a lot of, we involve patients. Not even nowadays, it's required of us to involve patients in the discussion of their care. So you discuss and agree, and agree this is what we want to do now. Let's see whether there's any improvements, and then you will come for a review. So it's a discussion.
Okay.
Yeah, because then we don't want everybody to run with their own diagnosis. Yet I am responsible for that patient.
Yeah, it's a good one though, because sometimes
WebMD will be like, you have 3 days to live. Oh well.
I guess there's nothing to do. Beyond trauma, there's the long-term rehabilitation that a patient needs. Is that part of what happens in the emergency room? Is there somebody whose mind is on, after the trauma?
After the trauma.
How do you then transition the person to the next, just in terms of mental wellness rehabilitation?
Okay. So in my hospital, sorry, I'm talking about my hospital a lot, but that's where I work. It's my comfort zone. We have psychologists as counselor in the department, and they're very important in two ways: to the staff and to the patients, and actually to the relatives. Because remember, there are cases that come to us that are unsalvageable, and we know they are unsalvageable. And we have to take through the relative. You're breaking that it's bad news to them that we cannot do much about this patient. So the psychologist is present 24/7, and they help the relatives go through that phase. Even for the patients who are able to understand and their diagnosis is terminal and they come in with a complication, the psychologist is able to do that. So we have counselors even in the wards who counsel the patient, because being in the hospital, say if you have a broken injury that takes you 3 months in the hospital, it's very stressing to the patient. You're not with your family, you're just there, you're waiting for treatment. They walk through with the patients, okay? And then for us, it's a high intense environment. We see trauma every single day. I wake up to trauma, I sleep with trauma, So the psychologists are very important. They've been incorporated into our system. We have a staff welfare program. If anyone is feeling burdened, then they go to the counselor. So yes, we do that. And even in disasters, we really make them part of the team, so that they walk through with the patients until they're discharged.
And with the caregivers, I would hope, you mentioned it, but with the caregivers as well?
Yeah.
Okay,
yeah.
All right. There's a question here. Oh, no, actually, it's a comment, and I think it's quite right. Dennis Mungai says, drills in schools can help get basic knowledge on first response in case of accidents like choking, fainting, etc. Someone fainted in high school, for example, and bit his tongue so hard we didn't know what to do. That's a very true example I know you touched on it earlier, but are there ways to integrate some of this first aid response in schools? For a lot of us, it came through clubs. If you weren't part of St. John's Ambulance, for example, you didn't know first aid. So it was either you joined St. John's or, okay. Is there a way to integrate it?
I think we need to talk to the Ministry of Education. Like I'm saying, intentionality. How intentional are we? This is health. I think health is very important.
Right.
And it might look like a small intervention, but actually incorporating this as part of the curriculum. The way we have PPE, what else do people do in school that are not examinable?
No, but you're right. Physical education,
they're not examinable, but then we teach, kids to do that. So we can have sessions that are actually planned. And we can have, there are many stakeholders
we teach about the menstrual cycle, pads, we teach that.
Yes. Exactly.
We teach around sexual health, and not from the biology perspective, but from, so you're right.
Intentionally. We should talk to Ministry of Education. And through the stakeholders, we have the emergency societies. I think that's a conversation that personally I'd be interested in being engaged in.
Yeah. I don't know how some things are not part of the school system. It really bugs me.
There's a question from Jackso.
Yes.
He's our director. So you can imagine him is just thinking about what he sees in the movies. In the ER.
Yes.
All right? Doctor arriving, patient arriving, and the EMS here, and ambulance has stopped. Is that what actually happens in an emergency situation?
Like take us through a day.
Give me 16 cc's of da-da-da-da.
Day at the trauma.
So say you does it start, for example, with someone telling you, there's an ambulance on the way, and this is the kind of patient that we have, prepare a room for this. How does it happen? Just take us through. Do the movie for us.
Yeah. But a caveat to that is that the system is not perfect. Sometimes we get a call, and we cannot tell how long they're coming. We don't have a lot of information. Sometimes they just show up, okay? So what we are trying to do right now, we've actually reorganized our call center. We are now renaming it into a call center. So we have a doctor who sits there, and will receive this call, and will actually give pre-hospital advice, what needs to be done. So we are running our own emergency call center as Kenyatta, and that is part of the reorganization that we are doing, because we realized if we don't do this, then we get very sicker patients. So what is happening is we tell them what to do. How long are you taking to arrive? But we want to move to the point where I can look in my computer, GIS mapping that 1 hour away, so that I bring in the correct people to manage the patient. If I need a surgeon, the surgeon will be there. All right? So it's a system that we are reorganizing. It is still work in progress, but that is the direction that we are going. So a patient who calls in, they come, a nurse in triage will receive the patient. we'll start the emergency care there, if at all it has not been started. You'll fix an IV line. If it's a critical patient, we take them to a critical care room. If they say they arrest, their heart stops, we have a resuscitation team that is already predetermined before a shift. Emergency is all about preparedness. You cannot prepare during the emergency. If you didn't think about it before the shift, then you will lose it. So before every shift, there's a team leader. It's a team of 6 people. So you can imagine how resource intensive, again. If I have 3 resuscitations going on, that means I need 18 people. Do we have that in level 4, in level 5? And those are the standards. Yeah. So we will resuscitate. So yes, all those things you see in movies, we do it at Kenyatta National Hospital in the emergency department. We've resuscitated patients successfully. We've taken them to ICU and they've gone home. They've actually walked out of ICU. So those are our success stories. There are those, of course, who are very sick, and that, again, is a different conversation with the relatives. But yes, give me this, give me an ETT, get me adrenaline. That's all part of the drama in the emergency department. And everybody, so the training is very important, because everybody should be knowing that this is a resuscitation. It's not the time to teach you, right? I cannot be teaching you at that time. I need to save these lives. So please give me adrenaline. Give me the ventilator. We need to intubate this patient. Can you do the correct compressions? So the knowledge. Everybody in the department should be knowledgeable. Yes.
Is there?
I was gonna
ventilator, AC.
Exactly.
What?
Dumb question. It's not even dumb.
No question.
It's that chest compressions.
Yes.
Yes. While done to like the tune of Staying Alive, are effective. Is that true?
Yes.
That is true. Oh, thank God.
You see?
Yeah.
You're somewhere.
Somewhere.
Not so bad.
Okay.
But don't be singing.
No.
Just do it.
Okay. Don't sing out loud. Okay.
I was going to say, is there a misconception that you want to debunk around trauma response, the emergency room, that you think is out there that you want to debunk for Kenyans?
Emergency departments work, I think. People should have faith in emergency departments, and more so even in public emergency departments. I want to say that very strongly, because all my life I've worked in public sector. I've never worked in a private hospitals. They probably have better systems. They have less patients. We have more patients, but we still do the emergency care. And I want people to trust the public hospitals, but also, and also Kenyatta, I mean, specifically where I am, we are able to resuscitate you when you come. And that is now super specialization, like we were talking about. Yeah, we have the right tools to be able to save a life. There's nothing we cannot manage in the hospital. But again, this again to the people who are decision makers. Let's be intentional about funding public health systems.
Absolutely.
Because that's where the majority of patients. And I was even giving someone an example. If my child collapses in the house, God forbid, the first place they'll rush to is where the mother works. So are we ready? Probably I'm not even in that shift. But is the system ready to take care of that patient, regardless of status?
Thank you. This was so important. Thank you so much, Dr. Janet Sugut, emergency physician, Kenyatta National Hospital. Trauma and emergency, what you need to know. We hope you know better now. We've had doctors today. We thank all of them for coming. We'll come back again tomorrow, 6 a.m. to 10 a.m. Mariam Bishar, Eric Latif, Janet Bogwa. Coming up next is Your World on NTV and Vibe Shift on Nation FM. We'll see you back here tomorrow.